Thank you. Can you see the presentation?
Yes, please.
Yeah. So basically, what you have is a 1 minute. Just let me move this. So this is a 40-year-old male reported to us actually 2015 with a mild reduced vision in the left eye of 6, 9, and 6. Right eye vision was okay, but on examination, what we saw is both eyes is having angiomas. Systemic history and family history was non-contributory. This patient underwent over a period of three sittings of TTT in both eyes at a 3 to 4 months interval, and then he was doing fine. So this is a picture at a third visit. He was holding on well. Then this is a seventh visit over a 3 years now. Absolutely fine. Angiomas are scarred, though left eye had some exudation here in the nasal side. But this was like a 17 January. In 2 months later, he comes with a, and vision is maintained here, both eyes 6, 6, and 6. And then he comes back 2 months later with a left eye sudden drop in vision. This was like our fundus drawing, total detachment in the left eye. Right eye is fine, holding on throughout till now. And this is 2018, having exudation, complete total retinal detachment. Obviously, it was rhegmatogenous, and this is what we did. I think you see the video playing.
Yeah. We can
So
see the
have a
video.
vitrectomy we did. You lot of subretinal, intraretinal exudation. This was one angioma here. This is another angioma, and this is a big another angioma. So we try to induce a lot of fibrosis, as you say, and when you try to trim, you see these dilated vessels and feeder vessels. Vitreous was stuck. Lot of fibrosis. Try to peel the vitreous off. So as much as possible, as much we could do. Just and this is what started oozing here. Well, I forgot we did case in under local anesthesia, not a general anesthesia, not a hypotensive anesthesia, and then trying to induce peel this fibrotic vitreous off. I won't say membrane, but basically it's a fibrotic vitreous. Managed to get this out, and you see amount of fibrosis these cases can have, and this can be really, really messy. And most of the time, you have a breaks at the base of the angioma. That was I was cauterizing one of the feeder vessel, and this is what it started oozing now. When this edge, because of the posterior hyaloid, when you try pulled and you create a break along the edge of this posterior margin of the angiomas, it started oozing here somehow. Raise bottle high pressure, then eventually did a fluid air exchange. In spite of that, it was oozing. So what happened is ultimately I had to do a mechanical pressure holding my cutter right over that feeder vessels. So initially, generally we plan cutting the feeder vessel and then like a draining vessel. When you see, even with fluid air exchange and pressure of almost 70 or 80, as you see here, it's still oozing, active bleeding. And so eventually what I did is I just keep direct mechanical pressure, keep pressing on that vessel, holding for a while, and eventually it stops. So waiting for a few, maybe minute or two, re-injected the fluid. Of course, during that phase, I touched the lens, and subsequently, now this is a phase, whole thing as fibrous. To relieve the traction, I don't have choice but to do retinectomy along the posterior margin of these angiomas. These are one vessel. This is another vessel. We have two vessels here. We'll come to that later on. And this is what I was doing. Retinotomy followed by retinectomy, this entire peripheral retina, and then of course, resection of the angioma. And then when you come for this big angioma now, this is one vessel. And what I aim at doing heavy cautery to actually ensure that you disconnect the vessel directly, like not like a trial like cautery and then try to cut on it. Just my cautery itself is I'm going to just sort of separate the vessel directly from that angioma place. So probably that is relatively safer, though still it can cause some amount of bleeding. Sorry, uh, we go back halfway through. So, but eventually as it's, sorry, again, it's, I don't know why it is moving, suddenly jumping forward. So this bleeder, again, that vessel eventually gave way, but I could control the bleeding. One more time, fluid air exchange to stop that bleeding. And once that was done, as you see, yes, in between it one like little bit, you feel your heart is at in your mouth, whether I'm going to able to, so fluid air exchange, remove the air and then cleaning job for clearing the heme. And this is what you have retinoschisis also, and you have subretinal clot. Remove the entire clot here. Took little bit time to clear it off because he didn't want to tear retina further and also did not want to have traction on those fragile, those vessels which were just close with coagulation. And once you remove this clot, then it was easier because now no more blood supply to that angioma. So I just chew off entire angioma after that. Okay, and that's what this is the angioma. Now, see, probably because it's become a vascular, there is no more blood supply there. Completed the retinotomy all around. And once we have then reflected the retina, we have some subretinal blood clots because of long-standing detachment, had some fibrous band also. Those are removed, as you see here, followed by PFCL injection, flattening the retina, and laser all around. And this was picture what we could settle the retina at the end. And this is the fourth post-operative day. Subsequently, we followed. Now it's a 3-year follow-up. This January patient come back. He is maintaining 636 vision in the left eye. Right eye is still holding on throughout, but left eye is now, he's still maintaining 636 vision. Pressure is fluctuating between 10 and 8. The last pressure was 8 millimeter of mercury. Near vision is N12. And in between, because we have to remove the lens, secondary IOL implantation also was done. So he is stable, no silicone oil emulsification, and I have decided not to remove oil as of now, just following him. Thank you very much.